Hi, Vanita. Welcome.
Hey, how are you?
Good. I think we have a critical mass. So, Dr. Caparte, we want to share your screen and we will allow you to go forward.
Okay, I'm sharing it now.
Yes, there it is.
Perfect.
Okay, so can I go on?
Yes, please.
Okay. Okay, so um my name is Dr. Sobon B. Patton. Today for our monthly presentation, I'll be doing a case on an ovarian cystic mass. Uh, it's an 18-year-old female who presented to the clinic with a left lower pelvic mass with associated pain for 4 years. And pertinent on the clinical information is that she has normal menstrual cycle, and except for the pain which actually brought her to hospital, she had no other symptoms. An ultrasound was done and they had a complex heterogeneous mass with both cystic and solid components. So they had a diagnosis of complex ovarian tumor, rather not thinking which type actually it was. And because of the pain and the size of the mass that they found, which was about 10 cm, they did a cystectomy and remove the mass. During the operation, the entire mass was resected and there was no spillage and the tumor did not rupture. So gross exam. So I received this cystic mass with smooth external surface, which measures about 100 by 90 by 50 millimeter. And there was an attached fallopian tube. Cut surface of the mass show a multiloculated cyst with a lot of creamy and tongue material. And beneath the creamy and tan material, there was a solid component that actually measured about 20 millimeter across in dimension. And that was the only foci that actually was solid. So the gross picture is shown here, and you can see the how the tumor was. This is just wider view, just for more visible appearance. So largely, macroscopically, on the entire tumor, it was mainly of a cyst that contains squamous and then lined by stratified squamous keratinized epithelium with granular layer resting on a fibrous wall with vessels and mature adipocytes. This high power magnification of the squams and then the stratified squamous epithelium, and then towards the right side you see the fibrous wall. Now, when I sampled the solid areas actually show a lot of congested blood vessels, some areas with few macrophages and some inflammatory cells. That's high power or representation. And then there were other areas that show follicular cells that look exactly like thyroid. And then another part of the same solid area also had these blue cells, some forming follicle-like or secondary follicle within the wall. So these were the components that were actually present in the solid areas. Now, seeing all this, I mean, this was my first time actually seeing the thyroid follicular pattern within the stratified squamous epithelium forming some cysts. And then what really brought my attention that I need to present this is the formation of having this follicular appearance of what I expected to be round blue cell at that time. I couldn't really classify them as lymphocytes. And this raised my concern, and I was afraid that there could be some sort of immature component which I needed to actually pay more attention to. Now, these solid areas, to confess, the fresh sampling actually missed some of these areas. And then going back and remembering on how the tumor of the ovary need to be sampled, especially taking about one sample per centimeter, that caused me to go back and do a thorough sampling. So I had a total of 20 slides, even though most of them were repetitive, but then I had to find this particular component, which I was actually concerned, especially for this particular slide, which I saw. Even though I didn't see any arrangement of rosettes or so, but I was actually suspicious for this side. And on higher power at 20x, this is how the cell look. And then you can see some areas that look like maybe germinal center or so, but then they are just these round blue cells. And then on higher magnification, these are how the cells actually look on under the microscope. So after going through and thoroughly examining, I actually reported it has a mature cystic teratoma with a suspicious focus of a round blue cell, which I require IC for histogenesis. And that was what the report I sent, and then had a discussion with the gynecology, and told him that this is what I've had predominantly. It's menstrual cystic teratoma, but there's this particular focus that I can't really commit to by saying whether it's an immature part or it's just something different. And so that was my main reason for presenting this case. Hopefully, I had someone who was traveling outside, because up to now, I haven't started immunohistochemistry yet. So I did send a blog containing these round blue cells component forming follicles, and then they took it away. And the result came back some 2 weeks. No, actually, it came back 5 days ago. And then when I saw the result, that's how I like, oh no, then maybe I need to present the case, because these are things that actually I need to bring to the group so that it can be discussed. So for the discussion, the first thing is that this was the first time I have seen these components. I have seen a monoteratoma with Mendel stroma ovary before, but never saw the stratified squamous part and other thing inside. It was just a monoteratoma. But seeing this with thyroid follicular part or macroscopic appearance, and also seeing the other component of a dermoid cyst like, and then putting all together, and then seeing the other part with these round blue cell clustering in one area, actually encouraged me that I need to present this case. And also looking at the importance of having immunohistochemistry in helping to solve some of these problems that may arise. And also for learning process is the importance of doing thorough sampling, especially for the ovarian tumors, which we actually need to sample per a centimeter surface area. I think that is very important, and that taught me a lot of lesson in recent time. So thank you, and I open for discussion. Or should I give the result for the immunohistochemistry? Or should I wait?
What this is, whichever way you would like to do this. You're leading this discussion.
Okay, so then let me leave it like this, and then when we discuss then all the possibilities and the teaching that will come, then I can just give what the immunohistochemistry came up to, because I got only the report and I actually requested the slides or so which I could use, but the lab couldn't send it to me, so they only gave me a report.
Zuditu, do you want to comment first?
Yeah, I'm thinking of mature cystic teratoma. If the thyroid follicles are not greater than 50%, can be still acceptable as part of mature cystic teratoma. And the small round cell component, I take it as just lymphoid follicles for me, just morphological.
Louis, do you want to give your thoughts, or do you want me to go first? What would you?
No, I'll be happy to mention that. Yeah, so I think there are a couple of things that come to my mind, and that is, when do you separately comment on the presence of thyroid epithelium? When do you call it just a mature cystic teratoma, or when do you call it struma ovariae? And my preference or my indication is usually to always comment on the presence of thyroid components for a couple of reasons. One, there are certainly instances where there may have been hormonal influence, and you might potentially even have had a bump in metabolic activity, or even a change in their voice, or other symptoms that could be related to the presence of the removal of a significant portion of thyroid tissue in the teratoma that might have been partially sustaining their metabolism or other functions. So it's always, I think, good to make people aware of that. I think the risk of secondary malignancy out of thyroid tissue is also a little bit higher. And so again, thoroughly sampling that to make sure that you don't have papillary carcinoma or some other thyroid neoplasm is pertinent. Then the question of evaluation for immature teratoma with the small blue cells, I think is a very interesting question, because I've seen a number of instances where people will see things that they think are neuroglial elements that are not, either because they see something that looks a little bit like a rosette, or in this case, because you have what appears to be lymphoid tissue with germinal centers and so forth that could be mistaken. I think the biggest issue is occasionally on frozen section, and that's where I think it's very easy to miss an immature component of a teratoma. But in general, the small blue cell infiltrate is usually admixed with the small blue cells of neuroglial tissue are usually admixed with other glial tissue and or other soft tissue elements and so forth. This mass looked quite discrete, and that would be, to my experience, a somewhat unusual pattern for an immature teratoma. So I think that was a clue that you're probably dealing with a benign infiltrate. Of course, the germinal center also, I think, helps to verify that. And then just the overall presence of lymph node with germinal centers in mature teratoma, in my experience, is quite unusual. So I think, again, reporting that might be interesting to include, although obviously I don't think it would have any prognostic or therapeutic implications. It's just a quite an unusual scenario. So those are my thoughts.
Okay, I guess my turn. So I pretty much agree with what everyone has said, which is that overall this looks to me like an immature teratoma. I too, like Lewis, will mention that there is focal thyroid tissue within the teratoma, although officially, in order to call it struma ovarii, you need 50%, I think, thyroid tissue to call it struma ovarii. With respect to the small round blue cell proliferation, I kind of agree with you on that also, that it doesn't have the rosetting architecture, and I have never seen there's almost always you can get I've never seen a predominantly cystic immature teratoma in which the cystic component is occupied by a dermoid component. I have seen it with a mucinous type tumor, but not one that is predominantly dermoid. There was an old paper describing something about minor immature elements, so I don't think that that meets. I'm not sure that I would have been concerned about immature teratoma on that one. I actually have an interest in lymphoid infiltration in the teratoma. When I was a resident, I had a case, and teratoma is associated with autoimmune, in a very small number of cases, with autoimmune presentations, which can range from autoimmune anemia, autoimmune related thrombocytopenic purpura, and most recently the NMDAR encephalitis syndrome. So I also mentioned the presence of lymphoid infiltration in the teratoma, especially if it is associated with neural tissues. There seems to be a higher association of young women presenting with NMDAR encephalitis when the inflammatory infiltrate is associated with glial tissue. So I do mention that although there are some reports of NMDR encephalitis related to teratomas in which neural tissue was not identified. Your point about thorough sampling is an interesting one. If the tumor looks grossly like a mature cystic teratoma, and there is not a worrisome solid component, that is actually one tumor in which I will not submit the high number of sections. A teratoma typically has one nodule from which the growth occurs, the so-called Rokitansky nodule. And so I just tell the residents to sample that solid area well, but I don't see particular need to submit the simple cystic component with keratinous, when the content is keratinous. So I don't know about that. Obviously, if you're concerned about something, then immunohistochemistry is is definitely helpful. When in doubt, obviously, it's good to do some sort of a confirmatory test. So I'll stop there and back to you, Dr. Caparte, about what happened with this patient.
Okay, so with this
I'm
patient,
sorry, I'm going to interrupt. I have one last thought to make. With respect to, and Lewis sort of hinted at it, secondary malignancies in teratoma, you can actually have lymphoma arising in teratoma, and there are case reports of follicular lymphoma arising in a teratoma. So just throwing that out there. I don't know how large this focus was, so not sure that you know, obviously if it raised the concern, then yeah, you would do the BCL2, the BCL6, the CD10 and all of that. But all right, now I'll stop.
thank you so much. So in this patient, when I sent the report, I actually had similar concern, but it's just the uh the blue cells that were plenty in one area, especially the entire solid area was about 45 millimeter, and it was not as big so. But then as you take from the top where the first section passed, it's like the serious section in that area. As I was sampling, I was getting at the top different, and then going down, I got different things. So I got more of the thyroid related tissue from the top, and then going down. Then I started getting these blue things as I did the extra blocks. And that was what made me to like, no, then I need to go and actually take a lot of samples and see maybe there's something else that I'm missing. And that's what made me to go up to the total amount of slide that I went to. And after looking at all, predominantly it was mainly the stratified squamous part that was there, except for some small foci or so that had all the thyroid tissue and the lymphoid aggregate. Again, when I look at the lymphoid aggregates, I actually saw the germinal center also, but then there were some areas that they were actually diffuse, and the germinal center was somewhere far on the other side. So it was quite difficult for me to tell whether this is completely lymphoid and I could stick up my neck for it. So because of that, I like, no, this is something suspicious that I myself need to be suspicious of. And so I reported it as that, and then send the report and discuss with the clinician on what my suspicions were. But I told him largely it's a cystic teratoma and this. And honestly, this is my first time for me to see a lymph aggregate within a teratoma. I've seen many teratoma, but to see a lymphoid aggregates, I haven't seen them. And for me to see the mixed part of thyroid-related tissue, most time I saw it only with the monoteratoma. But this one, they were small, sitting there, and then I had this part. So I like, am I getting a mixed picture here or so? That was what was getting me a bit confused and needed to take more keen attention to actually focus and go and see. So I did send the blog and then the date, and it was actually CD45 positive. And also they did the other markers, and it didn't show anything relating to lymphoma or so, but just mainly of lymphoid cells. And so I just did an addendum report and told him that the suspicious area turned out to be just a lymphoid aggregate with germinal center, and there's no concern for malignancy or immature components. And that was how I concluded. But it was something that I thought about, and I like, well, maybe I don't know how many persons have seen this or so, and it's better to bring it out, and then maybe we can have a discussion around it, and then I could also learn from it and see. So that was it. And presently the patient is up fine, doing well, and she was discharged some days ago, and hope that she will come for follow-up for surgical wounds and other things. That will be done by the the gynae people or so.
I have a not case, sort of not pathology diagnosis related question. How do you like where do you send the immunohistochemistry?
So I send my immunohistochemistry to Accra, Ghana,
Oh,
where I actually was practicing and then had to transition and then come back home in Liberia. So when I said I was transitioning, I was actually coming back home to come and work. So because I worked there for quite a long time, so I do send cases there, and then I'm in contact with Roch to see if I could get a setup, or have to liaise with my hospital administrator to see how best we can have that set up and get things running. So I send my breast cases, my lymphoma cases, and some other cases that require immunohistochemistry to Accra, Ghana. And I use the Kolebu Teaching Hospital Department of Pathology, where I actually was working for quite a long time, and then also sent to another private lab with pathology or border, and some Indian group there do some other molecular studies, which are the metropolis. So I try to liaise with all of them and see which one can really help me and get things sorted out.
that's awesome.
But at my center, I'm really pushing to have an immunohistochemistry to help solve some of my problems.
Louis, you were saying something?
No, I think that's I think that question of is it the appropriate time to bring in testing is a difficult decision wherever you are. You know, even if you already have immunohistochemistry set up, the decision about bringing on more antibodies or those sorts of questions are complex discussions because you have to look at your supply chain, you have to look at your reimbursement, you have to look at the expense of setting things up and so forth. So it's a very non-trivial issue. But then, of course, once you get a platform working, then adding additional things becomes a little bit less challenging. Still a significant expense, and you have to worry about the inventory and volumes and making the finances of the situation work so that it can be sustainable. And then looking at what to include on your panel, what will be useful in your setting versus what will be a waste of money or something like that. Those are also very interesting and challenging questions that I think always quite individualized based on what your case mix is and what your therapeutic responsibilities are and so forth. So yeah, I empathize with your challenge in terms of both getting the funding to start it and justifying the funding. We don't always have a simple single tool that says, plug in your volume of expected tests, plug in the cost of the reagent, plug in the outdates, plug in the equipment costs and so forth, and then turn the crank and bingo, here's your answer, do it, don't do it, et cetera, et cetera. It tends to be quite individualized in that regard.
Oh,
So,
Dr. Okwe just joined. Dr. Okwe, would you, I don't know when you joined. Do you have any thoughts?
I don't think you saw the case presentation.
I'm so sorry. I just joined.
Ah.
I had a lot of challenges with network. I'm just able to join.
Okay.
I'm so sorry.
So this was a case of a mature cystic teratoma that had some thyroid elements and also what looked like lymphoid hyperplasia. So that was what the discussion was about. I'm sorry, did someone say something? Okay.
So if you'd like, Vanita, I do have that case I
Oh,
mentioned,
yeah.
the fallopian tube lesion. I could share that, a few images from that, because I think that's another sort of sampling interpretation issue that sometimes comes up. So, Dr. Kiparte, do you want to stop your share, and I'll share my screen?
Yes, please. Let me stop.
Okay. So this patient was a patient who had had multiple gestations, and was not a particularly vigorous in terms of, or rigorous in terms of follow-up. So let's see if you're seeing the right screen or not. Are you seeing my presentation view, or are you seeing the real slide?
I'm just seeing a black screen. I'm not
Not
sure
yet.
about.
I
It
think
hasn't
it's trying
come.
to come on. The screen is trying to come on. Okay,
There's
it's
Okay, it's
on
on.
now.
Okay, so she'd had multiple gestations, and I think she was para 6 or something of that sort, with a recent delivery of her last child, and she wanted to undergo an elective salpingectomy at that point. And so, the surgeon dutifully snipped the tubes and sent us a resection of both tubes. And in one of the tubes, we had this partially disrupted appearance, which you see here, where you've got a lot of pink tissue over here on the side. Let's see, go to the next slide. Looking around a little bit further, deeper sections, we had an intraluminal fibrinoid and hemorrhagic area. And then down here at the lower portion here, you've got a little bit of almost vaguely granulomatous-like appearance, or at least some cells around pink structures there. I started wondering, oh, is this a granulomatous or a salpingitis or something of that sort? But then it looked a little bit more fully, and you began to see these very hyalinized pink nodules with some surrounding areas. There's a high power view of that one that looked vaguely granulomatous. It doesn't look like it's granulomatous. It's just a surrounding rim of cells with slightly clear cytoplasm. And here you can see there's a little bit of clearing in them, and even a few multinucleate cells. And you're probably picking out that we've got some, decidualization type changes in some of these cells with more abundant pink cytoplasm. So by this point, I was, pretty convinced that this was a placental site nodule. And here's some other areas of very hyalinized, associated with old hemorrhage and hemosiderin and so forth. But I had never seen this in a tube before. And so the question came up to mind, well, is this related to her recent gestation? Is this just a decidual placental site related to the current gestation that she just delivered? Or is this, in fact, as I ultimately came to believe, more likely a placental site nodule related to a prior ectopic pregnancy that has involuted without rupture, without therapy, and so forth. And so I went back to her history and looked a little bit more carefully to see kind of what the scenario was. And it did appear that about a year and a half ago, that she had come in for some abnormal bleeding, and had a D&C, but no other studies. They hadn't documented pregnancy or done an ultrasound or anything of that sort, but that might have been an abortive gestation that she had at that point that had spontaneously involuted, leaving this placental site nodule. I've had a long-term interest in this lesion just because it is the sort of lesion that tends to stick around for a long period of time. And in fact, the same week that this came through, I had two postmenopausal women who had prior, or who had a endometrial biopsy, which showed varying stages of this lesion in their endometrial curettage. And I remember very well the first time I reported this in a postmenopausal woman, the clinician called me back and said, well, this lady is postmenopausal. I don't think she's had a recent pregnancy. And that, of course, is one of the hallmarks, is that this lesion can stick around for literally decades after the gestation occurred, much as a cutaneous scar or another lesion that might lead to some residual collagen deposition or something of that sort in there. So just to sort of summarize, the placental site nodule gives you this scar-like tissue that's following due to the involution of the decidua related to implantation, and it can persist in that location in the endometrium, in the myometrium, or in this case, in the fallopian tube for years, maybe decades, and onto and beyond the childbearing age group. And usually it comes to presentation because they maybe develop some bleeding or they have a polyp or something of that sort of thing. One little pitfall in this is that these trophoblastic or decidual cells here, these clear cells, can occasionally show a few squamous markers like P63, maybe some cytokeratin and so forth. And so in cervical samples, for example, if you've had a low anterior presentation or low implantation in the cervix or endocervix, sometimes that can lead to a potential pitfall to consider squamous carcinoma. But if you're aware of this lesion and the sort of nodular architecture of the very pink tissue, you probably won't fall into that particular pitfall. So, questions, comments? Anyone else ever seen this in the fallopian tube?
Lewis, I have a question. When was her most recent pregnancy?
She was immediately postpartum and was having this self-injectomy as a within the week of delivery.
And
so there actually elsewhere on the tube there was a little bit of true stromal decidual type change on the serosa.
Huh, interesting. And had she had an ectopic previously?
She had never had an ectopic diagnosed, but she'd had that episode of abdominal pain and some bleeding that got her a D&C maybe 18 months ago. Whether that was the episode of the ectopic, I don't know. But she'd had multiple prior pregnancies, and at what stage she had the gestation that led to this fallopian tube implantation site, I don't know.
Interesting, very interesting case. Very cool. I mean, I guess the only other thing that I would say for this case is that, people have proposed that the placental site nodule, the trophoblasts in the placental site nodule are so-called chorionic trophoblasts. And so they're P63 positive, and this is the site of origin of epithelioid trophoblastic tumors.
Mhm.
And so there is, quote unquote, the entity of atypical placental site nodule. I personally don't like that label because trophoblasts are naturally atypical. So how would you determine true atypia? And some people have said that, you know, a high Ki-67 over 10% or something like that might help discriminate. But these lesions often have an inflammatory infiltrate, and it's difficult to tell which cell is staining. So I don't think I've ever used that diagnosis, but I know that that's the other sort of question that sometimes comes up. So yeah, very cool. Very interesting case. Any other comments? No.
Does anyone want to hold their hand up for a case for next month?
Yeah, I could present next month.
Yes, I will
Dr.
present the case
Masharia.
next month.
Okay,
Awesome.
so that was Benson, and who else was?
Dr. Okekwe.
Okay, okay,
I'll present the case next month.
great.
Awesome. So we have 2 cases for next month. So awesome.
You have lots of time to prepare.
Okay, I guess I don't really have anything to share, but I will have cases to share. I may just actually post the images to you guys because I have a case that's sitting right here, polyarteritis nodosa, diagnosed based on her hysterectomy for leiomyoma.
Oh my goodness.
And then this one is a follicular lymphoma of the endometrium.
Wow.
But they're not yet fully completed. So I will probably just post images on these cases. They're just so rare, but I'm feeling very good that I picked up on it. You know, it's one of these things where you look at it and say, yeah, it can't be. And then you take a closer look and do a chart review and go, oh, I would have missed it but for that split-second decision. But unfortunately, the patient does have polyarteritis.
Well, we'll look forward to those cases for sure, Vanita.
Okay.
I have a question.
Yes, please.
Yes, Dr. Masharia. Sorry, I've joined while driving, but I have a case that I've just reported right now where adult granulosa cell tumor, while in the other ovary, we are seeing kind of endometrioid type adenocarcinoma, and this is replicated within the omentum. So my question was, I was wondering, these 2 different tumors, one is granulosa cell tumor, while the other one is more of endometrioid, whether this is a possible occurrence.
The endometrioid tumor is in the ovary or the endometrium?
Endometrium is free of tumor, it is normal. However, one ovary shows endometrioid type adenocarcinoma, while the other ovary shows granulosa cell tumor.
And how big is the granulosa cell tumor?
That one was about 7 to 8 centimeters.
Interesting.
Actually, in the other ovary, it shows the endometrioid is just a focus. However, that is replicated in the omentum.
So I guess I have a couple of thoughts. I would be very careful about the focus in the omentum and make sure that it truly is endometrioid carcinoma that is metastatic and not a separate focus of endosalpingiosis, endometriosis. So, obviously you have looked at the case. So if the tumor in the ovary is clearly, high grade and high grade, then obviously the omental lesion is metastatic. But if the ovarian tumor is contained and low grade, then I would look carefully at the omental tumor and make sure that it's not a stroma sparse focus of endometriosis. I have seen endometrioid of the ovary with granulosa cell tumor. I think I've only seen one case, and my assumption was that it was a serendipitous association. But there are reports of endometriosis with sex cord-like elements in the wall of the endometriosis. So I guess that can happen with any type of ovarian tumor. So, but interesting coexistence. I don't know that there is a specific clinical implication. Louis, your thoughts or anybody else?
Yeah, so I mean, I think always we try to put findings into one diagnosis rather than multiple diagnoses. So that possibility that you either have a pseudo endometrioid granulosa cell tumor
Right.
that has a more endometrioid appearance on one side, I think should be carefully evaluated with, maybe some immunohistochemistries to see if you've got the more granulosa type phenotype. Obviously, granulosa cell tumor can be a hormonally active tumor, and so it could be stimulating a focus of endometriosis or whatever to produce an endometrioid carcinoma. But I think the possibility that it's all one tumor with different morphologies should be ruled out first.
Yeah, you're absolutely correct about that, because endometrioid carcinoma can also have sex cord-like elements, and so I just assumed from your description that these were two discrete tumors, but obviously, as Louis said, the first thing to do is to make sure that they are discrete and spatially distinct if you think they are two separate tumors.
Okay. Yes, I've requested for inhibin first, just to make sure we are dealing with the granulosa cell tumor. Maybe what I could do next month, I could just maybe flash the images
Yeah.
for us to see. Yeah.
Okay.
Thank you. Thank you.
I think you're muted, Louis.
Well, I guess if no one else has any more comments, we can wrap up and give people a minute or two back on their day.
Yep. And
Thanks,
we'll see
everyone.
everyone next month. Thank you.
Yeah. Thank you, Dr. Caparte, for presenting.
Yeah, thank you very much. That was a great presentation. Thank you. All right, everyone. Bye.
See you next month.